You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are talking with ONS member Roberta Kaplow, Clinical Nurse Specialist at Emory University Hospital in Atlanta, Georgia, and member of the Metro Atlanta ONS Chapter, about the latest nursing management and prevention strategies for malignant pleural effusions. This episode is part of a series about oncology emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me again today, Roberta.
Thank you for inviting me back.
So to start us off, I'd like you to give us some background on malignant pleural effusions. Let's talk about what it is and how does it present.
To understand what a malignant pleural effusion is, as I did last time with cardiac tamponade, I need to just journey us back to nursing school where we learned about the pleural space. So both the lungs and the chest wall are lined with a thin membrane called the pleura. And the lung is typically fully expanded in the chest and comes right up to the chest wall. As such, the normal pleural space, which is the area between the lung and the chest wall, has a small amount of fluid. Typically, it's around a teaspoon or so. A malignant pleural effusion is an abnormal buildup of that fluid. Cancer cells can also be part of it, and all of this collects in the pleural space. It's a fairly common complication for a number of different cancers, which I'll get into in just a little bit. If the cancer grows in the pleural space, it's called a malignant pleural effusion. And pleural effusion can be a sign that the cancer has spread to the lymph nodes.
Thank you. I think it's great to kind of go back and understand that physiology with some of these things that we have to talk about in these emergencies. So are there certain populations that are at a higher risk for developing malignant pleural effusions?
Yes, pleural effusion can be caused by many different diseases, including cancers and infection. In general, the fluid builds up in the pleural space, or there can be an overproduction of fluid or a decreased absorption of fluid, or both. And a malignant pleural effusion forms when cancer cells spread to the pleural space, as I mentioned earlier. The types of cancers that put patients at risk for developing pleural effusion: lung cancer is probably the most common one in male patients, and breast cancer is most common in female patients. Both male and female patients or patients with mesothelioma are more likely to get a malignant pleural effusion. In fact, patients with mesothelioma, in those patients, about 90% of the patients who have that cancer will also develop a malignant pleural effusion. Other sites are ovarian cancer, kidney cancer, stomach cancer, and colon cancer. Then there are cancer treatments that also put the patient at risk for developing malignant pleural effusions, and those include pretty much a good number of our patients who undergo radiation therapy or chemotherapy, and then patients who have either abdominal surgery or lung surgery. Other conditions, aside from cancer, that can put patients at risk for malignant pleural effusion are those with pneumonia or airway obstruction or lung collapse, and those with poor nutrition. I mentioned poor nutrition last time in cardiac tamponade because typically those patients have low protein levels, and the fluid will leak into the third space, which in this case is the pleural space.
How can nurses recognize that a patient might be experiencing a pleural effusion?
Well, first, knowing that the patient is at risk is essential for the oncology nurse. And I can probably tell you a million stories of nurses who are, I hate to use the term heroes because it kind of raises people back here now these days, but we have a heroes program where I work, and we identify people at risk early, and then the ongoing symptoms that patients may develop. In terms of the symptoms that patients can get, These can be really extremely variable and have a range. Some patients may have no symptoms at all, which would make it really difficult for the oncology nurse to pick it up. And in some patients, the symptoms will be very bothersome. Probably the largest or most significant symptom will be patients having progressive dyspnea or shortness of breath even at rest, or it could be with activity as well. And this occurs in probably half of the patients with malignant pleural effusion, and it's due to a lot of factors, probably the most common of which is loss of functional lung space. It could also be related to atelectasis or decreased compliance of the chest wall, which means the chest wall won't be able to stretch. Patients may develop chest pain or heaviness or pressure. Some, that's variable in terms of how patients report that. Some patients develop hemoptysis, and typically that's associated with endobronchial lesions or lung lesions. Patients can report a dry cough, pain when taking a deep breath, or feeling that they can't take a deep breath. Some patients have fever. Many have fatigue and inability to lie flat. They'll have decreased exercise tolerance or a decreased ability to do even simple physical activity. They generally feel unwell. And some patients, depending on the stage of the cancer that's causing the malignant pleural effusion, those patients may also have cachexia.
So now that we know who is going to be at risk and what some of their symptoms are, what is the diagnostic process for these patients with a suspected malignant pleural effusion?
There are actually a number of diagnostic procedures the patient may undergo. First, before the patient goes anywhere off the unit, the patient will have a physical exam. The respiratory exam findings usually suggest a pleural effusion, depending on how much fluid is accumulated in the pleural space itself. And the symptoms that we talked about earlier will be most often seen. The first diagnostic test the patient will probably undergo is a chest film or a chest X-ray. And chest films are typically abnormal in patients with a malignant pleural effusion because a standard chest film can pick up as little as 50 milliliters of pleural fluid in the space. Following a chest film, patients may undergo a CAT scan of the chest, which actually is the gold standard of imaging for these patients. The CAT scan can also provide useful information of the pleural cavity as a whole. It can look at the primary tumor site. It can even pick up some information on staging of the underlying tumor. And so a CT of the chest is an important investigation for patients with a malignant pleural effusion or a suspected one. Some patients will undergo an ultrasound of the chest, similar to in pregnancy, which we monitor the status of the fetus. We can do the same thing for a pleural effusion in the chest. And it's one of the best methods of imaging the pleural space because even a small effusion can be detected with the ultrasound. It's a non-invasive test. It doesn't hurt. Usually, if the place is nice, they'll warm up the jelly for you so the patient doesn't have cold jelly on their chest. And then when a malignant pleural effusion is suspected or confirmed, the provider will need to take a sample of that fluid to see what's causing the effusion. And this can be done in one of two ways. One is a thoracentesis. A thoracentesis can be done as an outpatient if the patient is not hospitalized. An ultrasound will be used to identify where the catheter should be inserted so there's no mishaps, and fluid will be drained with a needle and a syringe over a few minutes, and then the catheter or the needle is removed. If that's not possible, the second alternative for diagnosis of the type of or the underlying cause is a thoracoscopy with a biopsy. And this is also known as VATS, V-A-T-S, or video-assisted thoracoscopic surgery. This is slightly more invasive of a procedure, and it's generally done if a thoracentesis doesn't tell the provider the cause of the effusion. It's typically done under moderate sedation, but it can be done under general anesthesia. The provider will make a small incision between the ribs, the fluid's drained out of the space, and a camera is stuck in there and inserted into the chest cavity to visually examine the pleura, and then they'll be taking biopsies. In some cases, a VATS can be formed as an outpatient procedure. However, the provider may want the patient to stay in the hospital for at least a day following the procedure for observation. Next is a pleural biopsy. Pleural biopsies is another method to diagnose malignant pleural effusions to demonstrate the malignant cells in the pleural space. The results are usually smaller compared to the cytology and not typically used as much, but it can be done.
So, Roberta, what are some of the possible complications of malignant pleural effusions that patients are going to experience?
Patients with a malignant pleural effusion can develop lung scarring. They can develop a pneumothorax as a result of the complication of the thoracentesis. That's why it's important for us to use ultrasound when we're doing the thoracentesis. Helps guide the needle away from causing a pneumothorax. Patients can also develop an empyema, which is just a collection of pus within the pleural space, or sepsis if the procedure is not done under the best of conditions. And then, of course, there are complications associated with the procedures themselves. For example, a VATS procedure, those complications are typically mild, but they could be a little more significant and include hemorrhage or hypotension, cardiac dysrhythmias, an air leak, subcutaneous emphysema, fever, wound infection, and possibly empyema again.
So, for these patients, you talked a little bit about the diagnosing process and what those complications are, but now let's get into treatment interventions and what is used to manage this oncologic emergency that patients might experience.
So the primary goal in treating a malignant pleural effusion is primarily palliative to improve quality of life and reduce symptoms. And while the majority of patients with a malignant pleural effusion will experience symptoms that will affect their quality of life, some actually do remain asymptomatic and can be observed as an outpatient. And then prior to considering any therapeutic intervention, patients should undergo the aspiration of fluid and to see if fluid reaccumulates. It's important for nurses to know that fluid can reaccumulate. This is not a one and done thing. So in general, selection of the most appropriate approach of treating the patient should be individualized. And we also want to consider patient preferences because they should have a say in the therapies that they're going to be undergoing. If cancer is causing the effusion, the thoracentesis or the VATS procedure will help the oncologist select the best meds to treat the cancer. So first, in terms of treatment, there's simple observation. Again, just watch and wait. See if once a malignant pleural effusion is drained, if it's going to come back, if it'll reaccumulate. If it does, a thoracentesis can be approved. And the thoracentesis is the same procedure we did for diagnosis, but can also be used for treatment, which is draining out all the fluid. Again, an ultrasound is used before the thoracentesis to see if there's enough fluid to drain. If patients have poor performance status, such as a KPS, or if they have minimal life expectancy, and the patient has an underlying cancer that's chemosensitive, such as lymphoma or small cell lung cancer, these patients can be managed with just fluid aspiration. It's important for the oncology nurse to know that the fluid drainage may not improve survival, but it can certainly help the patient feel better, which is a gift in and of itself. The drawback to this is that over time, the effusion again will likely recur, and this will lead to repeated uncomfortable procedures, frequent hospital visits, and getting poked in the lungs a lot of times. Patients can also develop what's called re-expansion pulmonary edema. This doesn't occur very frequently, but if we remove more than 1.5 liters of fluid, they can get pulmonary edema symptoms. Patients can also undergo pleurodesis. Pleurodesis is probably one of the most commonly used treatment strategies. It's considered in patients with a malignant pleural effusion who aren't suitable candidates for a pleural catheter, which I'm going to talk about later, or if systemic chemotherapy or radiation has failed. Pleurodesis can be done either by placing a small catheter between the ribs into the fluid and instilling a chemical through the tube, or by thoracoscopy and spraying the chemical on the inside of the chest wall. And this does the same thing similar to what we talked about when I talked about cardiac tamponade, where you're using one of these agents to cause inflammation. Some of the agents that are used are similar to the ones that were used in cardiac tamponade, such as tetracycline, bleomycin, cisplatin, doxorubicin, etoposide, fluorouracil. But we can also try for pleural effusions, interferon beta, mitomycin C, methylprednisolone, and talc. Talc was also used in cardiac tamponade. and it's probably the most commonly used in pleurodesis because there is meta-analysis in there that supports its use, and that's very strong evidence. Probably one of the more common treatments, once the patient's been drained once and the fluid has been reaccumulating, is insertion of an indwelling pleural catheter. What we used to do when I was a mere lass, starting my oncology nursing career, we used to keep people in the hospital with these chest tubes with, they're wide and they're hard plastic. They're very uncomfortable. And we would keep these hard plastic tubes in people's chests until the drainage would slow down. And sometimes in some situations, it doesn't slow down and people would be in the hospital for extended periods of time. Now, some nice company invented a catheter called a Pleurix catheter, and it's an indwelling pleural catheter. It's gained a lot of popularity over the last decade because it allows patients to go home and drain themselves and just go on with their normal life. What they do with an indwelling pleural catheter, it's just a silicone tube. It's placed in the pleural cavity. It's tunneled subcutaneously. And then when the patient feels that there's fluid accumulating, this could be every day, it could be every other day, every third day, maybe once a week. But when the patient has symptoms, they can simply attach a drain to the drainage catheter, the silicone tube, to a drainage catheter, a tube which looks like almost like a football. And it's done under sterile procedure, and the family is taught how to do this, or the patient can actually do it him or herself. Then once the fluid is removed, we discontinue, we throw it away. The patient is taught how to drain it or how to dispose of it, and we're good to go. Another treatment is surgery. If other procedures don't work, surgery may be indicated. In some cases, surgery may be needed to look at the pleural space to get additional biopsies and do the pleurodesis. Patients may undergo on surgery, they may undergo what's called a pleuroperitoneal shunt. And the shunt is used to bypass and divert the excess fluid. And that's been usually used on patients with a significant anticipated life expectancy. Probably the most aggressive surgery is called a pleurectomy, where the pleural space is removed because the pleura is removed. This, again, is a high-cost procedure. It has high morbidity, high mortality. And again, it should be reserved for patients with significant anticipated life expectancy, not patients at end of life. All these procedures are costly. I'll just say that again, because that's a consideration for some patients and families. Medical oncologists and radiation oncologists may also treat the patient with chemotherapy or immunotherapy or radiation therapy or any combination of these to prevent the fluid from reaccumulating. The role actually of intrapleural chemotherapy for the management of a malignant pleural effusion is kind of controversial. It's hopefully designed to reduce the number of cancer cells in the pleural space, but its efficacy is pretty doubtful if the tumor is disseminated.
So, Roberta, there's a lot of options for patients who are experiencing this oncologic emergency. With all of those options you talked about, what would the role of the oncology nurse be in those interventions?
Again, first identifying patients at risk and knowing what they're going to be undergoing, providing patient education and support during diagnostic testing and treatment. And probably the most significant nursing contribution is pain management. A lot of these procedures are associated with pain either during or after the procedure, especially pleurodesis. So pain management is going to be mission critical. In terms of patient education, the company that has the indwelling pleural catheter has a wonderful DVD that is given to the patient when the catheter is inserted. And the patient takes the DVD home. We review it with the patient in the hospital. So the patient can watch a step on the DVD, pause the DVD, do that step, then hit the DVD button again and continue to the next step. It's very easy to follow. I've taught many a patient how to do this, and it's been highly successful.
So, Roberta, with everything we've talked about so far, and the different patient populations that all oncology nurses work with, are there any age-specific considerations for patients who are experiencing a malignant pleural effusion?
Well, I'll just say right up front, I don't have experience with pediatric patients. I take care of adults. But for the gero-oncology patient, it's important for the oncology nurse to know that older patients may be less resilient, so they may bounce back a little slower, recover more slowly from any of these diagnostic procedures or therapies. And with the medications for diagnostic testing, such as, I mentioned some of these procedures are done under moderate sedation. The general rule with gero-oncology that I remember learning in school was, start low and go slow. So kind and gentle with the medications, even if you have a moderate sedation protocol. With the gero-oncology patient population, you want to just start a little lower and start low and go slow. And in terms of the education you're going to provide, age, unfortunately, has some associated changes in vision and hearing. And so you want to tailor your patient education based on your patient's ability to see and hear. So if you're going to be giving written materials out, for example, you want to make sure the font is large enough for the person to see. You also want to try to avoid using fonts that where all you have is capital letters, because those are typically harder to read. That's not necessarily true just for the gero-oncology patient population, but for everybody. But it's important for those patients as well. So those are my gero-oncology considerations for malignant pleural effusion.
You mentioned earlier how you have taught patients how to manage with some of the interventions for managing malignant pleural effusions. What education should oncology nurses provide to patients who are at increased risk for a malignant pleural effusion?
Oncology nurses have such a pivotal role in terms of the education we provide. It's a privilege to do it, but it's so vitally important and should not be underestimated or rushed. First, you want to explain to the patient when they should call the provider and what symptoms to report, especially if they're going to be experiencing symptoms such as fatigue or decreased physical activity. It's really easy for a patient with a cancer diagnosis to say, oh, well, of course I'm fatigued. I have cancer. Oh, of course I can't do that really well anymore. I have cancer. And really, that's not really the excuse. The excuse is they're probably having some symptoms related to a complication or an emergency. And with any emergency, the earlier you report it, the earlier it gets treated, and the less complications you'll have associated with it, and the more resilient you'll be. So when do you call the provider? What symptoms to report? Get plenty of rest. So it's almost like prudent heart living or prudent living. Get plenty of rest. Explain to patients that they should avoid physical activity that may intensify pain or breathing problems. You can try to prevent a recurrence, such as maintaining a healthy lifestyle, such as eating healthy foods. This will help with overall health. Healthy foods are the same foods that we learn about with prudent heart living that we learned about in school. Fruits and vegetables, whole grain breads, low-fat dairy products, beans, lean meats, and fish. And of course, limiting sugar and alcohol and fat, which is, of course, what makes everybody feel good about themselves, but can't have those in large amounts. Certainly not smoking, drinking lots of liquids. Liquids help keep your air passages moist and helps the patients get rid of germs and other irritants. If patients have cardiac history, they should ask their provider how much they should drink. I don't want patients to go into fluid overload or pulmonary edema because I'm telling them to drink liquids. So you want to collaborate with the multidisciplinary team to make sure we're giving them guidance that's consistent with their other comorbidities that they're bringing to the health situation. Patients may feel like they need to rest more, so slowly start doing more and more each day, resting when they feel that you need to. Exercise regularly, and exercise doesn't have to be going to the gym and doing 5 or 15 miles on a treadmill. It could just be walking to your mailbox or walking around your block a little bit. They'll lower your blood pressure, decrease stress, and it'll generally make you feel better. So those are the things that I like to teach patients when they're having a malignant pleural effusion.
Well, Roberta, I want to thank you for all of the information you've shared. I think these podcasts that we are focusing on oncologic emergencies are so important because they are things that every oncology nurse is probably going to experience at least once in their clinical practice with patients. And it's just good for those of us who have been in practice to have a review, as well as for those new nurses who are listening. So as we come to the end of our podcast, I want to ask you a few questions to finish us out. And I'm just going to ask those in a real quick fire manner. And the first one is, what are common misconceptions about malignant pleural effusions?
Probably the most common misconception about malignant pleural effusion is that it's one and done. So again, all right, I had this complication, I got it drained, it's taken care of, done. Won't happen again. That's a misconception. As I mentioned a couple of times during this podcast, the fluid can reaccumulate, and there are steps we can take to prevent that.
Next, what's something about malignant pleural effusions that's not often discussed, but you wish people knew more about?
Sadly, the life expectancy is usually short in patients with malignant pleural effusion, and that's why the approach for treatment is usually palliative, involving the drainage of the pleural fluid and preventing reaccumulation. The median survival in this patient ranges probably from somewhere around 3 to 12 months, depending on the site, the stage of the cancer, and the type of malignancy.
What additional training or education do oncology nurses need to manage patients with malignant pleural effusion?
The oncology nurse should probably become familiar with the Pleurex strain. Again, I mentioned the DVD is so very helpful. The oncology nurse could probably get one from the company just to have one in their site, just to keep one so they can be comfortable with the step-by-step procedure. And then probably it would be most critical to help to assure that the patient or the caregiver or both are able to perform the drainage and change the dressing prior to discharge.
And finally, what are some additional resources for patients and providers who want to learn more about malignant pleural effusion?
For nurses, I mentioned this in the Cardiac Tamponade web podcast as well. I really appreciate the information in the Kaplan book, the Understanding and Managing Oncologic Emergencies. It is an ONS book. Yeah, all of the oncologic emergencies, including malignant pleural effusion, are explained really well. And all the testing and all the treatment are discussed as well. For patients, there actually is a really nice and simple patient information. It's a 2-page form from the American Thoracic Society. And all you have to do is just type in American Thoracic Society, malignant pleural effusion, and it'll come right up. But if you just go onto Google, very easy to navigate. It has pictures. The font is good. It's explained in good language. They use bullet points, so it's easy to read, like for the symptoms. Very helpful for patients and their families.
Well, Roberta, again, I want to thank you for joining me today to help us with this side effect or emergency that patients could experience. Do you have any final comments for us?
I guess my parting words would be that malignant pleural effusion is a common manifestation in patients with advanced lung cancer and other malignancies. And despite the various well-tolerated techniques to control malignant pleural effusions with pleurodesis or the long-term catheter drainage, all of these management approaches are palliative. And finally, I hope that the audience finds this information helpful and that it makes a difference for patients and families.
Thank you so much for joining me today.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.